So our next speaker is Dr. Soumya. Dr. Soumya is a talented oculoplasty surgeon. She's practicing at various hospitals across Calicut. She'll be speaking on the topic Beware of the Watery Eyes, an oculoplasty surgeon's perspective.
Good morning all. Thank you Dr. Ambika for this opportunity to talk about watery eyes. So why a cataract surgeon should be beware of watery eyes. So the most common causes of watering like blepharitis, ectropion and NLDO can lead to a postoperative endophthalmitis. Also there will be postoperative increase in watering in most of the patients, so it will affect their quality of life and the patient will be unhappy. So studies are shown that epiphora after uncomplicated phacoemulsification can be biased due to those who had previously suffered from epiphora. So preoperative evaluation, detection and counseling is a must. So what are the common causes of watering? It can be either increased lacrimination, lacrimal pump failure or obstruction in the drainage. So about increased lacrimination, it can be due to anterior blepharitis, either staphylococcal or seborrheic. The signs include erythema, edema, telangiectasia, scaling of the lid margin, madarosis, poliosis or trichiasis. So maintaining lid hygiene is a must, and topical antibiotics and corticosteroids will help to control the infection and improve symptoms. So posterior blepharitis or meibomian gland dysfunction is a chronic diffuse abnormality of meibomian gland, terminal duct obstruction, changes in meibum secretion and microbial proliferation. So all this reduction and change in the meibomian secretion will lead to disruption of the tear film lipid layer and increased evaporation. So there is prompt loss of ocular hemostasis and contributing to tear film instability and increased tear osmolarity and ocular surface inflammation and cell apoptosis. So this dry eye and meibomian gland dysfunction is a spectrum, so it should be treated as a single entity. So for evaluation, we should know the morphological changes in the meibomian gland using a meibography, and the function of the secreted meibum should be assessed using tear film breakup time, tear interferometry, tear osmolarity, etc. And a normal test for dry eye also should be done. So for management, lid hygiene is a must. We can done it using baby shampoo or hypochlorous acid based cleansers, warm compressors, ocular lubricants and topical anti-inflammatory like corticosteroids and cyclosporin for long-term use. Omega-3 fatty acids and tetracyclines and macrolides can also be used. So if that fails, we can go for second-line office-based treatments. The important ones are the thermal pulsation device like LipiFlow or intense pulse light therapy. Cataract surgery is known to alter the normal ocular surface milieu, which can last up to 6 months postoperatively. So these symptoms can be exaggerated in patients with ocular surface disorders. So knowing what all, if the patient has an immunological or non-immunological causes of ocular surface disorder is a must, because they can lead to non-healing epithelial defects and secondary infections postoperatively. So procedures for maintaining the healthy ocular surface like correction of entropion, ectropion or the lid margin regularization using IMG or MMG should be done before cataract surgery. And in patients of OCP, systemic immunosuppression is a mandatory before cataract surgery. So also we should be checking for other causes of hypersecretion like corneal disorders, allergy, inflammation, and the patient has trichiasis, we have to epilate or electrocauterize the lash. And eyelid retraction, lagophthalmos and ectropion can lead to exposure of the conjunctiva and cornea and hyperlacrimation. So we have completed the hyperlacrimation part and we are moving to lacrimal pump failure. So it can be due to age-related loosening of the eyelids or due to facial palsy. So there is difficulty for the tears to pass through the lacrimal drainage system. So this unstable lid can either go for ectropion or it can form an entropion. In that case, it can again, so the ectropion and entropion has two mechanisms of watering, either due to pump failure or because of exposure discharge, and which lead to reflex tearing. So in these patients, we have to look for horizontal lid laxity and tone of orbicularis muscle, either using pinch test, snapback test, and medial and lateral canthal laxity also should be assessed. So the patient will have a patent syringing, but the fluorescent dye disappearance test will be positive, that is retaining of the dye more than 5 minutes after installation. So for this patient, we have to tighten the lid, either using a lid lateral tarsus strip or wedge resection. Ectropion, entropion correction should be done. If everything fails, we should go for DCR. So third is the obstruction of the lacrimal drainage system. So the assessment of the lacrimal drainage system should start with inspection of the punctum. Size, site and position of the punctum is very important. If there is any acquired stenosis, it can be caused by involution, inflammation, infection or topical medication. The topical medication postoperatively also can produce punctal stenosis and watering. So eversion of the punctum and away from the tear plaque, that is known as the punctal ectropion, should be picked up. A red swollen pounding punctum can be a sign of canaliculitis. So pressure over the punctum or the canaliculus will expect purulent discharge in canaliculitis, but the lacrimal sac area will be normal. So lacrimal probing will get a graty feeling because of the concretions. So warm compressors, digital massage, milking of the concretions and topical antibiotics are the first step. Otherwise, we can also inject antibiotic intracanalically and canaliculotomy is the last resort. So Rhoplast, that is a regurgitation over pressure over the lacrimal sac, is also a important test. So if the Rhoplast is positive, it's suggestive of an NLD obstruction. But if there is blood along with that secretion, we should rule out dacrolith and most importantly lacrimal sac tumors. Sometimes the patient will have Rhoplast negative, but there will be a encysted mucocele. And sometimes there will be a dilated sac, Rhoplast negative, and on pressure the sac empties into the nose. So that is suggestive of atonic sac or internal or lacrimal sac diverticulae. So lacrimal irrigation and diagnostic probing is very important. In lacrimal irrigation, as we know, we can get a regurgitation from the same punctum if there is a canalicular obstruction, and through the opposite punctum if there is a common canalicular or NLD block. So in that case, diagnostic probing will help us. If we are getting a hard stop on probing, that is suggestive of NLD block, and if you are getting a soft stop, that is suggestive of common canalicular block. So if there is a canalicular stenosis, we have to repeat the syringing through the other opposite punctum to see the patency of the NLD. So gently advance and try to bypass the stenosis. If that is not possible, we have to go for canalicular trephination with monocanalicular stenting. So bicanalicular stenosis, we can try trephination, conjunctival DCR. If everything fails, we can do lacrimal gland based procedure like Botox injection. So for common canalicular stenosis, actually if the block is in the common canaliculus, there is no chance of any infection, but always rule out underlying NLDO in case of common canaliculus block. So do a DCR when in doubt, and if the patient is more worried about watering, better to do a DCR and lacrimal intubation before cataract surgery. So if there is NLD obstruction, definitely we have to go for either for dicrocysty or rhinostomy or DCT and wait for at least a month before cataract surgery. So the evaluation of the epiphora would not be completed with the evaluation of the nasal pathologies like turbinate hypertrophy, rhinosinusitis, polyps and septal deviation. So to conclude, if the patient comes to you with watering, you have to look for the ocular surface, lids, lacrimal passage and nasal examination should be done to understand the cause. And before the cataract surgery, it's better to evaluate the patient, and you should have a symptom and severity score to see whether the patient is having mild to moderate or severe watering, and preoperative counseling is very much important in these patients. Thank you.
Thank you, Dr. Soumya, for highlighting aspects about oculoplasty and how it's important to take care of the nasolacrimal apparatus.